So CMAM's been a common part of our humanitarian or emergency programming, but recently, although DFID's been quite late to wake up to the global nutrition challenge, we have woken up, and in 2011 we launched a nutrition position paper which outlined our goal to reach 20 million pregnant women and children under 5 with nutrition services, additional 20 million with nutrition services. And then in June, this summer, we co-hosted with CIF, some of whom are here, and the government of Brazil, something called the Nutrition for Growth Summit, which was part of the G8. And that galvanized an additional 2.7 billion of financial commitments for nutrition, and a compact was launched after that with more than 100 stakeholders endorsing that and committing to reducing stunting by 2025. And DFID, as part of that, DFID committed to triple its nutrition funding by 2020. So as part of that expanding of nutrition spend at DFID, we're also programming CMAM differently through our country programs, providing more longer-term funding through national governments and our budget support work through health sector and other programs. A number of us from DFID went to the Addis conference 2 years ago, and that was quite a critical moment for us to take stock about how we are programming CMAM. And today we're going to highlight some of the ways that we're doing this differently in Malawi, Ethiopia, India, and Kenya. So in Malawi, and I want to highlight that Ruth is here from DFID Malawi, so this is really her slide. In Malawi, we're going to be working through the Health Ministry and UNICEF. And so DFID Malawi works with the Ministry of Health to treat SAM, hoping to reach 85% of health facilities. So there has been severe acute malnutrition treatment in nutrition rehab centres, but and also treatment at health facilities with RUTF. So it's really that the message here is that CMAM will be integrated within our support to the Ministry of Health and within our budget support programme with UNICEF. And there's also an exploration of local production of RUTF and with Valid International, and I think some funding now to Valid International. Okay, and then in India, which is where I've just, I came back in January from working in India for 5 years, so this is a subject very close to my heart. As many of you know, India has 40% of the global burden of severe acute malnutrition and virtually no treatment in the community. There's a very small-scale provision in Bihar as a kind of emergency response. But since 2010, and since the conference in Addis as well, there's been a slow advocacy process to try and to work with state governments in Odisha and Madhya Pradesh primarily to move towards piloting CMAM. And that's been a process where DFID's not only given a little bit of funding, but also worked to kind of try and broker relationships and work closely with Valid International. Steve's been out to India a lot and been doing amazing work to try and get pilots going in Madhya Pradesh and Orissa. And there's a variety of approaches that we want to test. Small-scale production with women's groups, comparison of community versus hospital treatment, and then also some potential local production in Madhya Pradesh. These pilots would be with state governments, with also the Right to Food NGOs who have in the past been sceptical about CMAM and about local production of RUTF. The Ministry of Health is about to issue CMAM guidance imminently. UNICEF's been working very hard on that. And we've been working across our sector programmes. So we worked primarily with health departments in Madhya Pradesh, Orissa and Bihar, and now work with the nodal department for nutrition and also the department that handles sanitation. And we're also working towards breaking, with Valid and others, working towards breaking the critical block around producing a public sector RUTF in India. Okay, now I'm over to Abby.
Thank you very much. I feel the disadvantage of being the second that I'm going to get
it was 9:46.
The buzzer. I'm going to have the buzzer. It's a bit terrifying prospect. So thank you very much to Anne. The next two examples that I'm going to talk about where DFID is trying to do things differently have both actually come out of our experiences in recent humanitarian emergencies, and notably the 2011 Horn of Africa crisis. And the reason I thought it was useful to give a bit of a reflection on some of the humanitarian dimensions is not to drag us back into the bad old days of short-term start-stop humanitarian funding for CMAM, but actually because these two experiences are providing DFID with quite a lot of useful opportunities to learn how to bring together more longer-term development approaches with much more of an understanding of risk and vulnerability and how to get flexibility into programs like CMAM. Which is obviously critical when you're dealing with quite fluctuating caseloads. And also quite critically, how a donor like DFID then needs to think about its own financing instruments. So I'm going to start with talking about Ethiopia, where we have recently had approved a £36 million multi-year commitment to support the Ethiopian government to scale up CMAM. And I'm going to apologise to my DFID Ethiopia colleague who really usefully provided these points. Please do read through them because they tell a really interesting story. But I actually wanted to reflect in this idea of what is DFID doing differently on some of the work that happened in advance of this particular agreement coming into place. DFID Ethiopia was actually at the forefront of responding to the criticisms from how DFID and other donors responded to the Horn of Africa crisis, and really was looking at seizing the recommendations from the Independent Commission for Aid Impact report, which said there needs to be predictable funding that can come in earlier to reduce risk, to reduce the likelihood of increasing caseloads of acute malnutrition, but also the need for contingency funding. And so this nutrition investment that's recently been approved is actually part of a whole suite of programmes, all of which are multi-year, and all of which have a degree of flexibility built within them. So there's ongoing support for the Productive Safety Net programme, including the risk financing mechanism, which is obviously quite an important way of reducing vulnerability and therefore helping to reduce fluctuations in acute malnutrition, hopefully. There's also multi-year funding for more traditional humanitarian food assistance, which includes within that a contingency fund. And this is really intended to try and help protect the vulnerable populations that are not being reached by government services. And actually, the contingency fund in this particular programme was quite an interesting moment for DFID and has prompted a series of conversations internally about how a government department can actually manage to have a pot of money that can be triggered in that way, but that might not be used. On top of that, there's also a multi-year commitment to the Ethiopian Humanitarian Response Fund. And this has just been re-agreed, which will span over the next 3 years. And this fund has actually traditionally funded quite a lot of nutrition. And it's to an early stage, look at how it combines with the longer-term support, so this multi-year commitment to scale up CMAM. But there's a really interesting opportunity to learn how do we ensure that humanitarian needs that are not being reached by governments still get addressed, and also how humanitarian, that kind of more flexible funding can help support some of the scale-up that needs to happen when you do see escalations in situations. So yes, what we're doing differently is this long-term investment in supporting CMAM scale-up, but there's all this other story around this, which I thought was hopefully quite interesting to share. So then moving on to Kenya, which has been another country where DFID has really seized recommendations coming out from the Horn of Africa crisis. So really coming out from that context, the team in Kenya put in place a £16 million 3-year programme, quite small money in comparison to the Ethiopia context, to support the scale-up of high-impact nutrition interventions across the arid and semi-arid land area of Kenya. And this is working through NGOs and also through UNICEF. And there are 2 dimensions to this. One is about supporting service delivery, so including the CMAM component, but also about working with the government and with the government systems to look at planning for nutrition and looking at system strengthening. This particular programme also has got really strongly in its mind concepts around flexibility and scalability, as well as this kind of vision of longer-term sustainability. So there are components in here where UNICEF is looking at issues around supply chain management and forecasting, and again thinking about understanding increasing or decreasing caseloads. Likewise, and this is quite an early stage, looking at HR surge capacity within that programme. And it's at an early stage. Kenya's gone through devolution over the last year, which has created a very different landscape for us to work in terms of scaling up nutrition. And there's also a separate but linked piece of work looking at broader early warning systems. So again, understanding risk and understanding vulnerability in a very risk-prone area. So working with the National Disaster Management Authority and looking at what kind of broader early warning systems and triggers are needed to understand when we need to scale up support. So to look at reducing the likelihood of increasing caseloads, but also to try and understand what that means for the nutrition programme. So unlike the Ethiopia programme, which is so early stages for us, so we haven't had an opportunity to reflect on that yet, we have just come to the end of the first year of the Kenya programme, and Anne Bush and I have just come back from Kenya, where we were doing the review of this programme. And a couple of key lessons or challenges that I think it was worth reflecting on. Looking at the time, the buzzer's not about to go. One of the really obvious things, one of the key things that colleagues have mentioned already this morning, is that it is really interesting to see the challenges of trying to integrate the wider nutrition services, but also CMAM, into actually what is already quite a weak health system. And this is really raising questions about what do we mean in terms of future sustainability? What does the health workforce need to look like to support this programme? There's an interesting dimension to that, which is about how nutrition is being perceived and how it's understood as part of a health package, and particularly when it comes to management of acute malnutrition. There was a lot of discussion this morning about coverage, about getting out there to be able to reach people and getting that community mobilisation going. But actually, the outreach services that are being implemented are still perceived as NGO-run, donor-funded nutrition. And therefore, that idea that these are part of a health programme is not understood. I think there's also questions then about what are we talking about in terms of a feasible model to give to the government when it comes to health workforce planning at health centre level versus thinking about more different approaches to trying to reach out to populations and create that demand. A couple of other things that came to mind when looking at the programme, obviously underlying causes in a context like Kenya is having a massive impact on fluctuations in acute malnutrition and therefore in the delivery of this programme. And obviously looking at investments to address those is really critical, but also there's something about understanding what are we talking about in the future? How are we planning a health CMAM programme when thinking about, are we ideally looking at reducing caseloads over time? How do we manage that dynamic? And then the other thing that did strike us in the Kenya example, I was so shocked that this funding from DFID is actually the main source of nutrition funding at the moment in the country, and that shocks me a lot. I know that the EU are in discussion about putting in longer-term funding for nutrition, but our kind of idea of doing multi-year funding is still to some degree being a little bit undermined by a lack of other donors coming and providing that kind of support as well. So, to conclude, reflecting on Anne's examples and then the examples I've just given from Ethiopia and Kenya, I think what DFID is recognising that at the moment for us, there is no one-size-fits-all approach to funding. Obviously, in an ideal scenario, we're looking at putting money through government, through budget support, but we are also recognising that there are contexts in which that simply isn't possible for various reasons. And I think in contexts where you're still dealing with humanitarian needs that are not being covered through government services for one reason or another, I think understanding how to ensure there is humanitarian funding and how we can still respond with some of that humanitarian principle is quite critical for us as a donor to understand, and how that our funding can fit together to enable that to happen. Also, what we recognise is that notwithstanding this issue about dealing with humanitarian needs not being covered through government, it is key for us to be working through existing or future policies and systems. We've got a new bit of funding that's been approved, multi-year funding for nutrition scale-up in Somalia, which is actually about working through health systems. Heaven forbid, it's going to be interesting. But again, that vision is there, even within that kind of context. And finally, I think that reflecting on these examples and some of the other ones, we have Rob Hughes in the room who looks after Yemen, where there's a really interesting experience going on there. it's actually a really critical period for lesson learning for us as a donor, but also for our partners. So there's been a lot of focus about getting awareness of this as an issue, getting awareness of nutrition generally. Lots of focus on planning, lots of focus on getting getting things in place, but actually understanding how implementation at scale happens and how we need to learn from that to strengthen the CMAM programs and other nutrition programs is going to be critical. I think there's also an interesting bit here around understanding how you build commitment, and that's not necessarily just among the political machinery in a country, but also among the kind of wider set of stakeholders. Hedwig and I had an interesting conversation in Kenya about the importance of, senior paediatricians, getting the health people on board to really bring this in as an intervention. And so linking to that, how we position nutrition into the health system and obviously particularly management of acute malnutrition. And then finally, my particular interest is coming from the humanitarian perspective, how we really can bridge the development, longer-term investments with a kind of concept of risk and vulnerability to get that flexibility into the programs, and how we as a donor can also make our funding work. Thank you very much.
Thank you very much.